Hello, everyone, and welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host this week and every week, and I am a filmmaker and writer that's been working with CCF for over 10 years now, folks, to create all kinds of video content, live video series like the one you're going to see today, patient-centric documentaries, treatment-based videos, event coverage, all sorts of videos, hundreds, maybe thousands of videos over those 10 years, but all with the same mission in mind, and that is to spread awareness and education about neuroendocrine tumors. Now, we had last week off, and so we were excited to be back. It looks like you all were excited too, waiting to join the room, so we love to see it. If you are new to the show and new to the community, I want to say welcome. Reach out to the people. You might see the people commenting already and saying where they're signing on from in the world. We'd love to see how far these programs reach. We already have someone from Nepal in the house, California, Canada, Connecticut, Alabama. Reach out. Introduce yourself to the people in the community. I promise you, they will embrace you. That is something that is so powerful about this net community, is the way they look out for each other. Part of the value of this show is the information you're going to get from the guest. But another secondary value that you get is the shared experiences and shared stories from within the community. It's just as helpful, in my opinion. And so I encourage you to reach out to them, and they will embrace you. So before we start, we always want to thank our sponsors, Ipsen Biopharmaceuticals, for their support of Luncheon with the Experts. We couldn't do the show without them, but we have this disclaimer from them that we like to say at the top of the program. And that is that the opinions expressed today by the guest, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts, and CCF does not endorse or promote any of the views, opinions, or information that will be provided in the presentation. Audience members should not rely solely on the opinions or information expressed today by the guest, and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, so that's a lot of words, as disclaimers often are, but the real takeaway is that last line. We or our guests do not know your specific case. So we're going to give you some great answers to your question, hopefully, and some good general advice. But by all means, take those back to your home team, which does know your specific case, and make the best plan and path forward for you. Because if there's anything that I have learned in the past 10 years of working with CCF, it's that every case of this disease is unique, and therefore every plan and path forward is as well. So today I am very excited to welcome a new guest to the show, Dr. Nitya Raj. How are you, Dr. Raj?
Good, and thank you for having me today.
Yeah, very excited to have you. You come highly recommended, I will say. So I'm very excited to get into the show with you. But for those who may not be familiar with you and the work that you do, what do you do, and what is the role that you fill in this net community?
Absolutely. So I'm one of the GI medical oncologists, or gastrointestinal medical oncologists at Sloan Kettering. And in my work, I both see patients in clinic, and I also conduct research, and all of my clinical and research efforts are directed towards neuroendocrine tumors. So my clinical practice is really focused in the care of patients with neuroendocrine tumors, and all of the research efforts that I am involved in center on neuroendocrine tumors. So I'm really dedicated and passionate about caring for those with NETs.
It seems so. You said the word all, 100%?
Pretty much, yeah. That's kind of all of my focus here. And so, I see a little bit of other GI cancers in my clinical practice, but more and more, my practice is really focused on neuroendocrine tumors.
All right, awesome. Well, folks, that's exciting news for me. Many of our experts on the show are 100% net focused, but many of them aren't as well. It's just part of their practice. So I really love this. This tells me we're going to get a lot of great, thorough information about this disease, which is what we're here to do, right? So go ahead and start sending in your questions. We're going to start taking them very soon. I have a little bit more housekeeping to get to, and then we're going to go ahead and start taking your questions and getting some of that information to you. So here's how the show is going to go. We're going to try to get to all your questions. Inevitably, we will not, because there are hundreds of them. So if we don't get to your question, I encourage you to follow up with CCF. We will try to get you that information. Come back next week. It's kind of a good problem we don't get to the questions, because it keeps fueling the show. We keep having the show every week, but we want to try to get to them. However, we we or our guests most likely don't know your specific case. So try to not ask them in a very case specific manner. If you can, try to be general with your questions so that it can help you. If if we need more information, or if you have a follow-up question and you're still in the call, chime back in again. Give me a little context, because I see tons of questions, to refer back to your previous question. But you can certainly chime in if we need a little bit more information from you. The value of this show, it will live here and be evergreen. People can watch it as soon as we're done recording today on the Facebook channel. Next week, we'll put it on YouTube. But the real value is this interactive session, one-on-one session with an expert, right? So getting a question across is important. If you know someone that should be here, or hey, we were off last week, if they've forgotten about it and they should be here, you haven't seen them saying hello and where they're from in the comment section, go ahead and tag them, share the video with them, let them know the show's going on, remind them that it's going on, so we can get as many people here as possible. And one more thing that I will ask, you all do a great job of this every week, so I will continue to ask it. If you see a question that you also have, or you're interested in the answer to, just under the comment or the question, you can like it, love it, or any of the emotions that Facebook allows you to use. They all work effectively the same way for me, and that is to upvote it. If I see 8 people have that same question, as I'm going through the hundreds of questions, I'm going to make sure to get that one across, because it will, a lot of people are interested in it. So that just helps me do my job better, which is, of course, to serve you. I see, who else do I see? Australia in the house. I was telling you, Dr. Raj, before we started, that we really have people all over the world tuning in live. It's so impressive. So I have a question. First of all, this is a common question that I ask. I'm always interested in what led people to the net space, because I feel like my hunch is that nobody goes to school, or like, their dream when they're, in high school is like, I want to be a net specific oncologist. So I'm interested in, like, what point did your career start driving you to that? And was there a moment, was there a story where you're like, no, this is where I want to spend my time and energy?
Absolutely. So, I think I was always drawn into medicine because I'm so passionate about the ability to care for people in person, and, developing really long-term relationships. And that's how that naturally navigated my path when I was a medical student into internal medicine. And as I got into internal medicine, I quickly realized that I wanted to be an oncologist, just the ability to provide that longitudinal care, but also as a specialist. And, I would say that me entering the neuroendocrine world was sort of fortuitous. I did my medical oncology fellowship here at Sloan Kettering. So I did all of my oncology training here. And when we're fellows in our second year, that's when we start to specialize. I'd always been very interested in gastrointestinal or GI disorders. So I just, I had done a lot of research when I was a med student in other types of GI diseases. And when I was in my fellowship, I was sort of naturally drawn to GI oncology. But really, I entered the neuroendocrine world because when I was looking for a mentor as a second year fellow, I was just very fortunate to meet with my mentor, who is still my mentor, and I could really envision myself, and I wanted to be that type of a clinician and that type of a research a decade from where I was. And it was just sort of fortuitous that, my mentor was really focusing on neuroendocrine tumors. And as I learned more about the disease, I felt that, it really satisfied all of my interests, my interest in GI cancers, because the majority of neuroendocrine cancers, though not all, start in the GI tract. But also that ability to form and have long-term relationships with our patients. And that, I will say we're so fortunate as providers for those with neuroendocrine tumors that thankfully, for many of our patients, we're able to care for them over a period of many years, if not, their entire lifespan. And as a fellow here, I did work in neuroendocrine, seeing patients, doing research, and then I had the opportunity to stay on faculty and continue my focus in neuroendocrine.
Yeah, you already answered one of my questions. I was going to ask if that long-term care aspect was one of the things, because as we know, that if you are managing this disease, effectively, it can be more of a long-term chronic condition. So I thought that might have aligned with your desire to have that sort of care.
Yeah, Oh, I
No,
was
no,
going to say
please.
the other thing that, I learned really as I was a fellow and starting to work in neuroendocrine was the very collaborative nature of this field. And so I think
Right.
what's so cool about neuroendocrine, and somewhat unique compared to other types of oncology, is that, we work closely with the surgeons, with the radiologists, with the endocrinologists, with now nuclear medicine physicians. And there are so many different fields that provide care for our patients. And I love that collaborative aspect to our work. I think that it drives us, it makes us think harder, and
Hmm.
it is truly one of the reasons that we have developed more therapies for neuroendocrine in the past decade than any other GI cancer.
Absolutely. Folks, we're going to go ahead and start taking some questions, but I did want to send a special shout out to Kevin from Holly Springs, North Carolina. I'm in Durham. So nice to see you. I think this might be the first time I've seen your name. So if it's your first time at the show, welcome. And I don't mean to play favorites, folks. I love you all, but my North Carolina folks, especially right here close to me, got to say hello. First question, Dr. Raj from Skip. Any possible use of the exciting new drug, which I actually haven't heard of this drug yet, dostarlimab for rectal cancer? And can you establish a little bit about that drug? I'm unfamiliar.
Absolutely. So this is really exciting and very recent data that was just presented by one of my colleagues, actually, Dr. Andrea Sursek, a few days ago at our big national meeting.
Okay.
Yeah, shout out to Dr. Sursek. But this was a study of patients with a different type of cancer, which is called an adenocarcinoma, which is truly a different disease of the rectum. And dostarlimab is a type of immunotherapy drug. And they saw that all of the patients with localized rectal cancers had a complete response to immunotherapy in the study. So it's super exciting data. We're thrilled for this advancement in GI oncology. I think right now, unfortunately, those results aren't directly applicable to neuroendocrine tumors. There's been a lot of work in immunotherapy in the disease, and we could certainly talk more about it, but that study was truly done in a different type of cancer.
Okay. Understood. Thank you. And thanks for your question, Skip. Okay, so Dr. Raj, I know that working with NET patients like you do, you probably already know that most of them are very well educated, and we see that evident in this show a lot. However, like some people, maybe Kevin, who I mentioned earlier, some people might be very early to this journey or first time at the show. So I always like to cover a lot of foundational knowledge, and not skip past it so easily. So the next question comes from Jennifer. It's a good question like that I get often. She says, Jennifer says, how are lung nets different than the others? And we get this question a lot, right? Because is it a lung cancer? Is it a net? What exactly is it? And what are the differences?
Yeah, I mean, I think that's a great question. And that's one that, I commonly get in clinic when I meet someone with a neuroendocrine tumor that starts in the lung. So, as I mentioned, most neuroendocrine tumors start in the GI tract, but the second most common site is actually in the lung. And, and even when I was in my training, they were thought to possibly be a little bit more different in terms of diseases. I think more and more we're appreciating that really we're talking about a very similar disease, and the approach to treatment is actually now essentially almost identical. So, the classification of neuroendocrine tumors of the lungs has evolved over the past few years. Our pathologists, who are the doctors that look at your tissue, are using very similar classification schemes. And actually, the approach to therapy is quite similar. So the big difference is the site of origin. We know that a neuroendocrine tumor of the lung is starting in the lung versus elsewhere. But in terms of when we're strategizing in how to treat someone that's been diagnosed with a lung net, there's not too much different.
Sorry, I coughed right there at the end. Thank you. Okay, that's great. That is thorough. If you have any follow-up questions to that, specific to lung nets or anything else, Jennifer, let us know. We'll be here for you. From Sherry, possibly Shari, can carcinoid or sandostatin cause severe imbalance issues?
So I'm guessing that what the question's about is whether the treatment itself can contribute to the symptoms that someone's having in terms of calling. in terms of seeing imbalance issues. And so sandostatin, which is also known as octreotide, long-acting release, is one of the first therapies that we will often consider for our patients, and it's a hormone injection.
Mhm.
And classically, we'll use it for two reasons. One, either to just control the growth of a tumor, or two, in someone that has a hormone releasing cancer, which can often manifest as the carcinoid syndrome. And the goal of the octreotide or the sandostatin in that situation is both to control objectively what we're seeing on scans, but also treat the symptoms. So most of the time, the symptoms that patients with the syndrome are presenting with are very bad diarrhea, very bad flushing, sometimes wheezing.
Mm.
It's exceptionally rare for the injections to actually exacerbate those symptoms. Sometimes, unfortunately, we don't get the control that we want in terms of the hormone release with the injections. And when that happens, we may have to think about other additional therapies that we can offer. But in and of itself, the injections don't typically make symptoms worse. Sometimes you can see a flare for about a day after the injection, where you can have a little bit more gas, bloating, frequency of your bowel movements. But beyond that, you shouldn't be seeing more of an imbalance.
Got it. Thank you. And if we didn't quite get that question right, which I think we do, that's the way I interpret it as well, Dr. Raj, just let us know. Next question comes from Marge and several other people. I do understand rather that some oncologists don't feel the chromogranin A test is reliable. However, if scans look stable, but chromogranin A continues to climb, should there be other tests to better understand the blood markers?
That is a great question, and one that I commonly get in clinic. And so, chromogranin A, like the viewer mentioned, is a blood test that we can sometimes check, and traditionally used to be followed for patients with a diagnosis of neuroendocrine tumor, with the thought process that if your chromogranin A is getting higher, the disease is more active. Now, there's been a lot of work done in the NET community to try to test this hypothesis. And it's been shown now that unfortunately chromogranin A doesn't always track with what the disease is doing, either clinically in terms of how you're feeling or radiographically what your scans are showing. Chromogranin A can change based on the time of day that it's drawn. It can be elevated in people who have problems with their kidneys or their liver. Certain medications, common medications for heartburn, can mess with the levels of the chromogranin A. So it has really fallen out of favor as a test for us to check. And in fact, really our practice here and my practice in clinic is to just not check the chromogranin A, because I find that I have no clue what to make of a chromogranin A that's rising a little bit in the context of someone who is feeling well, doing well on their therapy, and has stable scans. And I think it can create a lot of anxiety because we don't do anything with that information. And we know that there are all these factors that can impact the chromogranin levels. And, in fact, now in the more recent national cancer guidelines that we all work together to write and develop, it no longer states to even check these types of blood tests. So it's something that we really don't do anymore. So for someone who is clinically feeling well and their scans are stable, if the chromogranin A is going up, I don't get concerned about that at all. And I don't recommend doing further tests in that situation.
Got it. Thank you. Follow up to that question from Susan. She says, also, how much can PPI use affect this lab result?
Yeah, it's a great question. And again, PPI use can drive that chromogranin level up. To what degree can be variable from person to person. And like I said, there are all these other factors in terms of how your other organs are functioning, the time of day that the blood is drawn. And so, we really just don't even, that's one of the big reasons why we don't even follow that chromogranin level.
Got it. From Nancy, are there any long-term cautions or recommendations you have for those of us who have had parts of our bowel, in my case, cecum and appendix, and gallbladder removed due to NETs?
Yeah, so I think many of our patients and many of you have probably had big surgeries where you've maybe had parts of your liver removed or parts of your bowel or the gallbladder. And in terms of long-term recommendations, there aren't specific recommendations based on, the portion of the body that's resected.
Okay.
I will say in people who've had bowel resections, I think one of the key take home points is that, your bowels can be forever changed a little bit, but I do think that generally over a period of months to sometimes for some people a few years, they will settle into some normalcy. So that's a point that I really do try to stress and work with and talk to my patients about, because it can be a source of frustration. You've had this big surgery, you may not have any evidence of cancer, but you're dealing with some lifelong changes, which can sometimes impact the quality a little bit, but a lot of reassurance that things often settle over a period of time. I think the other big thing that we think about for our patients who've had surgeries, especially those with kind of bowel resections, is that they're at a little bit of an increased risk for bowel obstructions just from something called adhesions or kind of post-surgical changes that people can have. So we're always very cautious to tell people, if you have any pain that just isn't sitting right as a change, you're starting to have a lot of nausea or vomiting, just give us a call. Let's talk about it. Let's make sure there's nothing going on that we need to more urgently evaluate.
Got it. Thank you. Folks, if you have just joined us recently or joined us a little bit late, this is Luncheon with the Experts, a Carcinoid Cancer Foundation program. We are here today with Dr. Nitya Raj from Sloan Kettering, and a lot of great questions today, and I see many more coming up. So keep them coming, folks. From Enrico, what doctor do you recommend that I see for lung carcinoids? I have MEN1 and I am seeing doctors at Mount Sinai currently, but I would like a second opinion. And a few other people are interested in this as well. Any thoughts or suggestions?
Yeah, I think the key for neuroendocrine is to at least have a quarterback specialist. So I think we're seeing more and more people diagnosed with neuroendocrine tumors, and even many of my patients are being cared for closer to home. And then I see them more periodically because I have a focus in NETs. I know you're probably in exceptional care at Mount Sinai, which is a huge center in terms of neuroendocrine tumors. But in terms of getting other opinions, even within kind of the tri-state area, here at Memorial, we have a big program, Columbia. And so, we're all honored to see you for a second opinion, and we all work very closely together. So we're all very comfortable, with people soliciting and getting other opinions. Like I said, it's a very collaborative field. We all work very closely together, but any of us would be honored to see you.
All right, sounds good. Thank you. Next question from Betty. My husband gets the monthly shot and seems to cause severe diarrhea for a few days. Is there anything that he can do to help? He's lost so much weight, so I can tell Betty's concerned about him.
Yeah, and I think that's a great question. And I think one of the questions earlier asked about this imbalance immediately after the hormone injections. And, like I was saying, while it's rare to have many issues, sometimes we can see, usually it's the first 24 hours. It sounds like it's lasting a little bit longer. For this person, we can see almost an exacerbation of the bowel symptoms. So, in that situation, I usually don't forego the injections. I still try to keep them going because it can be such an effective therapy for the cancer, but we get very, very aggressive kind of with some of our medications that we can use for symptom management. So if he is not currently on an antidiarrheal, I definitely will add that on for a few days, anywhere from Imodium that's over the counter to some of our stronger prescribed medications like Lamodal or opium tinctures where we start. The nutrition piece of things can sometimes be very difficult, just kind of because of the location of this disease, and sometimes the symptoms that it can cause. The diarrhea is not always from carcinoid syndrome, but we know that there are other reasons why people can have the imbalance of their bowels. So I think that if he hasn't met with a nutritionist, I actually think that can be really helpful, because there are just some foods that can aggravate people more than other and can contribute to people having challenges keeping their weight up while they're undergoing therapy. So, and it's not necessarily a specific set just for someone just because of a diagnosis of NET. I think that's very individual. So again, it's getting the whole team as part of the care. So I definitely get nutrition involved in those situations, and I'm pretty aggressive with sort of some of the medications we can prescribe to support symptoms.
Got it. Thank you. And Betty, and this goes for Betty and everyone listening, really. I mentioned at the top of the program how many videos we have created with CCF over the years. And I say it every week. If there is a topic, I can almost promise you that there is a video about it, or maybe multiple, especially now that we've been doing Luncheon with the Experts. We talk about these topics. So I'm saying that to say we have videos on nutrition with some of the top nutritionists in this field. Also, we have had interviews with them on other Facebook Live shows and on Luncheon with the Experts. So we have a huge library, a huge database that is free, that is for you, for these purposes. So I encourage you to comb through that. If you need help directing or finding specific ones, you can reach out to CCF and we will help you do that. The previous question about lung nets, we have specific videos on lung neuroendocrine tumors as well. So this is something I want to constantly reiterate, is that we have all of this content for you all, that for those purposes. So that's another way you can get more value, or hopefully more of your questions answered after this show. Just want to make mention of that. From Helen, very commonly asked question that I get: can GI nets be inherited?
So rarely, yes, we can see GI nets inherited. It's atypical that that's the case. And most of the time, the disease is what we call sporadic, meaning that we don't know why you develop a neuroendocrine tumor. Genetic testing is now really standard of care for any cancer, given advances in our therapies that can be directed towards specific genetic alterations. So, there's two different types of genetic testing. And so one is testing in what we call the germline, which is looking in the blood to see if there's anything we can pick up that will point in the direction of an inherited cancer. And then the second type of genetic testing is testing in a tumor. That's a little bit different, because that's looking to see, is there a target that we could use therapeutically, to give a therapy to someone. So it's rare. There are a few genetic syndromes that can be associated with neuroendocrine tumors. MEN1 came up in a prior question. And, if there's suspicion for that based on a family history or other medical issues that someone may have, that will make us inclined to do the germline genetic testing. But if not, generally, we don't pursue that type of genetic testing. But then the somatic genetic testing is pretty much standard of care now, given how many new therapies we have based on the genetics of a given cancer.
Got it. Thank you. A question that I had from the beginning: I know you work with other GI cancers. What are the primary ways that GI net is different than other GI cancers?
Yeah, so I would say GI nets they're truly a very different disease than some of the other types of cancers we care of. Most of the other GI cancers that we care of are called adenocarcinomas, or adeno means gland. And so they're cells that arise, they're cancers that arise in the glandular cells of the body, whereas neuroendocrine tumors arise from the neuroendocrine cells of the body. So the first huge difference is just the cellular site of origin of the cancer. I think the other big difference between GI neuroendocrine tumors versus, colon cancer, or rectal cancer, or pancreas cancer is sort of the biology of the disease. I think that, while there can be a spectrum of behavior for neuroendocrine tumors and a lot of what we call heterogeneity, I think that's one of the challenges sometimes with caring for neuroendocrine tumors, is trying to understand that biology. In general, thankfully, these can often be more indolent cancers, meaning that they generally grow more slowly. And also in terms of their response to therapy, those responses can be more durable. So often with our treatments, and something we often talk about in clinic, given that these cancers grow much more slowly, our therapies often put the brakes on the disease. They stall the disease. We often don't see a ton of shrinkage on the scans, but we are totally fine and happy with that, because that's what you would expect in a more slower growing cancer. Whereas in like a cancer or colon cancer, which tends to grow just that much more quickly, we're giving treatments where we really expect to see a lot of shrinkage of the disease. So those are some of the big differences.
Got it. Thank you so much. From Joy, would you prescribe monthly shots of Sandostatin if the patient does not have carcinoid syndrome? What do you consider when determining if it is needed or not?
Yeah, that's a great question, and that's kind of one of the first things we think about sometimes when we're deciding whether or not to start therapy for this cancer. So, like I mentioned, the two main indications for starting the injections are either like something like carcinoid syndrome or symptoms related to the release of hormones. That in and of itself in the absence of kind of any growth of the cancer would be a reason you'd consider the injections. The other reason you would consider the injections is truly kind of for what we call cytostatic control of the disease, or that objectively you're seeing the cancer grow and you feel that you need to start a treatment to put the brakes on the cancer. Now, one of the key things you need to sort out if you're in that second bucket is you want to make sure that the neuroendocrine tumor has the target for that hormone injection. So, the somatostatin analogs, the octreotide or the lanreotide, those are the two injections you guys will see. They bind to something called a somatostatin receptor, which is unique to neuroendocrine tumors and is seen in the majority of neuroendocrine tumors, but not always. So one of the first things we'll do in someone who doesn't have hormone release symptoms, but we think we need to start therapy, is we'll do a special type of scan, a special type of PET scan to look for that receptor. And then if the cancer has that receptor, we will decide whether or not we're going to start the injection. So it's certainly used in patients who have neuroendocrine tumors, but don't have any sort of syndrome or hormone release symptoms.
Got it. Thank you so much. From Azad, when tumors metastasize to pancreatic lymph nodes, does it to all lymph nodes at once, or is it gradual?
Yeah, so it can be completely unpredictable. So, usually when you think of the way a cancer spreads, if it originates in the pancreas for like a pancreatic neuroendocrine tumors, there's kind of two methods of spread. One is through your lymph nodes. And whether it goes to one or many, it's hard to know. And the second is sort of through the bloodstream, meaning it goes straight to the bloodstream and moves through the blood to other parts of the body. The suspicion is that if, let's say you have a surgery and we see it in your lymph nodes, or we can see swollen lymph nodes on the scan, as oncologists, our suspicion is that there's probably more there than what we can see. Like microscopic disease in the lymph nodes, you're not going to pick up on a scan. And so that's our assumption. Whether that's truly the case for each person, we really don't know. There would be no way to remove all the lymph nodes. Even in a relatively big surgery, the surgeon wouldn't get every single lymph node out necessarily in that region.
Got it. Oh, next question from Fred and a few other people. Can a possible lung net, lots of lung net questions today. Can a possible lung net be diagnosed without pathology using surveillance of a thoracic CT scans over a few years, or by a certain blood test of sputum analysis?
Yeah, so great question. So, to my knowledge, there's no type of sputum tests really typically to diagnose cancer in general. So sputum doesn't really have a role in kind of diagnosing cancers that originate kind of in the lung or in the head and neck region. In terms of the second part of the question as to whether scans may give you suggestion of if you're dealing with a net versus something else, sometimes, I think it can be really tricky for lung nets because a lot of other types of lung cancers can grow really, really slowly too. And the imaging appearance can overlap. And so usually like a CAT scan on its own, like a surveillance CAT scan, is probably not going to give you the diagnosis of a neuroendocrine tumor, especially for those that originate in the lung. So usually if you're seeing something grow somewhat slowly and it's really confined to the lung, the question becomes, does it just get removed by the surgeon versus doing a biopsy at some point?
Mhm.
But classically, the imaging in and of itself isn't going to, like a CAT scan isn't going to cinch the diagnosis.
Got it. Next question from Ariane. Let me know if I'm pronouncing that correctly, but this is a big question, and it's one that I've heard several times before. Once you have NETs, carcinoid cancer diagnosis, do you have it for life? Is there ever a cancer-free?
Yeah. So most certainly, there could be a cancer. There is a point where we will. It's always a very exciting visit where we will say, we don't think you need to come back and see us. So that really happens in the situation where at the time of an initial diagnosis, it was what we call more localized disease. And I distinguish that from what we call more advanced disease, meaning the cancer has gone to another organ or another part of the body. So usually we're talking about this possibility of the cancer going away in the setting of localized disease, where you're able to undergo a successful surgery, where the surgeon removes what we believe is everything based on all of the tools and information that we have. Now, in that setting, we usually care for our patients and we do follow them for about a decade after the surgery, because very, very rarely this is a cancer that we can see again, even 9-10 years out from a really successful surgery. But at that point, at that 10-year mark, if we're not seeing any evidence of cancer on the scans or any other symptoms where we're concerned or suspicious that something could be going on, we would really discharge you from the oncology clinic and wouldn't recommend any further follow-up. And so, yes, it's possible in this disease that you could complete surveillance and not need to see an oncologist again.
Got it. Thank you. And thanks for your question. Next question. This is okay. Again, we're kind of still in the lung nets area, but this is back referring to a previous question we talked about, meaning like the differences between lung nets and GI. So Jennifer says there are limited lung net doctors. We've kind of alluded to that as well. And GI doctors won't typically, I'll say, take lung net patients. So if they're essentially the same as we talked about earlier, why is that?
So I think that's a great question. And I think some of it is, our understanding and the evolution of classifying and treating lung nets has really evolved more recently. I would say even as I came out of fellowship and into practice, I will say most net specialists or people who focus in nets in academic centers do often also see neuroendocrine tumors that originated in the lung. In some places, a team called thoracic oncology, there may be someone focusing in neuroendocrine cancers of the lung that will see these patients. But generally at bigger academic centers where there are people focusing in nets, those of us who are traditionally GI oncologists will also care for patients with lung nets. I think that one of the challenges for lung nets is and I should have spoken to this, is sort of the rarity of the diagnosis. They are rarer than GI nets. And so you can imagine with a rarer cancer, the ability to conduct big clinical trials to validate the therapy is harder. Now, there are certainly some studies that have been done that have included neuroendocrine tumors of the lungs. There are other studies that haven't. And, some of the work establishing the efficacy of the therapies that we use can come from what we call retrospective research, or where we kind of look back at our clinical practice and pull together the data. And so that's one of the challenges for lung nets, is that sometimes we don't have that big clinical trial data to drive our decisions. But that being said, the way we approach treatment is very similar, and there's a lot of kind of smaller data sets supporting that approach to treatment.
Got it. Thank you. Folks, we've got about 20 minutes left of the show. We're going to keep going and taking your questions, as many of them as we can get to. A lot of great questions again today. And also stay tuned at the end, please. Special announcement at the end of today's show. From Gwendolyn, is there a way to incorporate raw vegetables into the diet without increasing the risk of a bowel obstruction? Quality of life is important too. I agree with that.
Yeah. So I think this again comes back to kind of the nutrition piece of things in neuroendocrine tumors. And, my approach, when my patients ask me about dietary restrictions, what should I do? What should I not do? Especially in those who've had surgeries on their bowels, I would say that, I don't advocate for completely eliminating even raw fruits, raw vegetables. I think it's very individual from person to person. For some people, it can irritate their gut more. And in those situations, I think it's a little bit of experimentation. It might not be all raw fruits or vegetables. It may be one or two things. And so I usually ask people to experiment a little bit and keep a little bit of a diary, and foods that irritate you, you stay away from. Foods that don't, totally fine to have. I don't think everything needs to be eliminated. And I think the nutritionists that I have worked with and, have learned from have also supported that approach from a nutrition perspective. That being said, if things irritate you, then you really should stay away from them, because you can get your protein, you can get your nutrients in other forms. So I actually don't recommend completely eliminating raw vegetables. I encourage people to try a little bit.
Yeah, I think that's great advice. Great advice. It really is a lot of trial and error. From Terry, and Terry, let me know if I'm asking this, representing your question correctly, but this is another big picture question. Terry says, I have carcinoids. Can you explain serotonin? She says, mine is 758. So let's just talk a little bit about the role of serotonin in this whole thing.
Yeah, so serotonin is basically a product that can be sometimes secreted by neuroendocrine tumors, and it's most commonly secreted by the neuroendocrine tumors that start in the small bowel. So it's less common to see serotonin levels being elevated in someone. Well, we can see it, it's just rarer for like a pancreatic neuroendocrine tumor or a lung neuroendocrine tumor. Now, the release of the serotonin is what really it drives the carcinoid syndrome, or sort of that classic syndrome that is, whenever someone says neuroendocrine tumor, they think of flushing and diarrhea and wheezing. Now, the best way to really diagnose that syndrome is one, by symptoms. So first, if you meet someone and they're having a lot of symptoms, then sometimes I get concerned, oh, could they have carcinoid syndrome? I think the thing we all have to remember is it's actually very, very rare. So while it's popularized as being kind of the hallmark of a neuroendocrine tumor, it actually is quite rare. And the best way to diagnose it is actually not through blood levels of serotonin. Again, the serotonin checks in the blood are very similar to the chromogranin checks in the blood. We really don't know what to make of those levels. The key is actually to do something called a 24-hour urine collection. And in that 24-hour urine collection, we're actually looking for a byproduct that is produced and secreted in your urine if you have very, very high levels of serotonin being secreted by the cancer. It's something called the 5-HIAA. So an elevated 24-hour urine 5-HIAA cinches the diagnosis of the carcinoid syndrome in someone who has symptoms. So if I'm meeting someone in clinic, if they have no symptoms, I don't check a 24-hour urine. I only check that urine if someone has symptoms and I'm concerned. And then the next step then is to figure out, well, are the symptoms related to the hormone, or are the symptoms possibly related to something else? Because that's a real possibility too.
And this is a follow-up question. If you have, the question is, does carcinoid syndrome mean you have the tumor? So if you have those symptoms, doesn't necessarily mean that. Would it be diagnosed as that? I'm sure you can have those symptoms in something else, but doesn't necessarily mean you have a tumor.
So if you have those symptoms, and if your 24-hour urine is elevated for that 5-HIAA, the suspicion is that, yes, there's something hiding there. Usually with further workup, we're able to identify the source of it. Now, I will say there's a very, very, very rare subset of people who present with the classic symptoms, have elevated testing, and we don't find anything. We do scans, we do GI workups, and we just can't find anything. And obviously that can be very disconcerting and, unsettling. That's rare. I mean, we do see it, and we all care for patients in that situation, but that's typically unlikely. Usually, we're able to identify the source.
Got it. Thank you. From Jean, how often do you advise having a dotatate scan, or do you use it only when there is progression?
Yeah, that's a great question. And our use of dotates and when to use them and how to use them is evolving rapidly. Now that we have something called PRRT, which is a special type of radiation therapy for the disease. So the way we thought about a lot about this at our institution, because I think it's important for everyone to remember that the dotatate scans are definitely more radiation exposure for you as a patient. At least in comparison specifically to CAT scans. MRIs thankfully don't have radiation exposure, but also the dotatate scans are probably not the best way to really look at measurements of the cancer. So if you're really trying to understand over a period of a few months how the cancer has changed, the dotatate is usually not the way to go. A good quality CAT scan or MRI is the better choice. So the way I use dotatate are kind of in a few settings. Usually I'll do a dotatate at the time that I meet a patient and they're first diagnosed. And that's more just to get a sense of, well, does the cancer have that somatostatin receptor on it? And sometimes the dotatate scan can pick up disease in areas that the CAT scans and MRIs aren't as good at. And specifically that's the bone. So people can have a CAT scan or an MRI, maybe they have neuroendocrine tumor in their liver, and then we do a dotatate and we pick up some stuff in the bone. And I always do tell people before I get that dotatate, we may see a little bit more here. That's okay. That's not new cancer. It's just the sensitivities of our different tests. So that is the first time I'll usually do a dotatate is just kind of as a baseline when I meet someone to figure out the extent, especially of the disease, and how bright it is. What's that density of that somatostatin receptor? And then the dotatate scan, I don't typically do, every few months. I'm really using my CAT scans and MRIs to monitor the cancer more closely, the day-to-day changes. And the next time I'll often think about getting that dotatate is to strategize in terms of therapy. So if someone has gotten octreotide or lanreotide and the cancer is growing, at the point of progression, we may think about doing another dotatate as we're trying to strategize whether or not to try PRRT as a therapy. So those are kind of the instances where you'll most commonly see the dotatate used. But in terms of routinely doing it every few months, which I do see sometimes happen, that's something that I don't recommend because I don't think it's a value add. And from a cost perspective, it's a very expensive test too. So we have to think about all the tests that we're doing for our patients. And I think that our CAT scans and MRIs help us a lot more.
Got it. Thanks. From Kim, do gallium-68 dotatate scans show all tumors or just neuroendocrine tumors?
So so the gallium-68 scan, classically is going to pick up neuroendocrine tumors. I will say, sometimes you can see some brightness in other parts, including the thyroid sometimes will light up, even the pancreas will sometimes light up, and it's often what we call physiologic. So it's not cancer at all. It's just the way that the tracer is metabolized in those organs, but it's pretty specific for neuroendocrine tumors. So it's not approved for other types of cancers. It's not used in other types of cancers. So it's usually not going to pick up another cancer.
Got it. There was another scan question from Katie. Do you use copper scan over gallium? Which is better in your opinion?
Yeah, so I would say either or. So gallium dotatate is approved by the FDA, so it's readily available within the community and at major centers. The copper dotatate scan is in investigation. It may become more readily available, but for right now it's really largely available under research protocols. So we don't really know if it's better than the gallium. They've never been compared head to head per se. A lot of the work that's being done right now is to we clearly have early data supporting the use of it and to sort of potentially validate it as another type of nuclear medicine scan in the disease.
Would you advise sticking with one of them, or is it okay to go back and forth?
It's okay to go back and forth. I think that our nuclear medicine doctors are really experts in sort of cross comparison between the two. I think the key, though, again, is that you don't need that nuclear medicine scan every few months. That it should be very thoughtful when we're ordering that scan. It can be super helpful at baseline when you're thinking about PRRT. Sometimes it can be helpful in assessing response to PRRT, but it should not be an every few months scan that you're getting.
Got it. From our friend Tom, would you prescribe Zermello for carcinoid heart disease?
Yeah, so Zermello, we haven't talked about Zermello. And so Zermello is, a medication called telotrestat. And, there is data supporting its use sometimes for people with carcinoid syndrome and having GI symptoms or a lot of diarrhea related to the serotonin. And there's some evolving data as well supporting its use in carcinoid heart disease. One of the side effects of the serotonin, if it's being released by the cancer, is that it can, also potentially deposit on the valves of your heart. And so people with carcinoid syndrome are at risk of developing what we call carcinoid heart disease, which can present kind of with heart failure symptoms. So Zermello, there's kind of evolving data suggesting that, it could reduce the release of the serotonin, which would then mean less deposition in the heart valves and also reduction of, diarrhea or bowel symptoms related to the hormone. I will say that right now my practice is to first consider a lot of our other therapies, specifically, the lanreotide or the octreotide, even sometimes short-acting octreotide. And then, yes, I would consider Zermello for sure.
Got it. Thank you. From John, if platelets are low, is it helpful to see a hematologist to explore options regarding treatment?
So I think the question of whether or not we would recommend seeing a hematologist really depends on what we think the cause may be of the platelets being low. We can see low platelets for a variety of reasons for patients with neuroendocrine tumors. And, the two big reasons that we see lowering of the platelets in this disease are, one, it's related to a therapy that we've given you, specifically some of the chemotherapy drugs that we will sometimes use, a drug called temozolomide can lower those platelets. Or two, especially now that we are giving PRRT, one of the potential side effects is lowering of the platelets. Usually, if it's therapy related, we'll actually see the platelets get better slowly over time. Now it can take weeks to months, but we will gradually see those platelets kind of come back up. The second reason, if we don't think that's going on, sometimes, especially if someone has a lot of bone disease and we see the blood counts going down and the platelets going down, we can get worried, could there be something going on in the bone marrow, like cancer related, that's causing the platelets to go down? And our hematologists can really help us sort that out. And so it really depends on the situation. That's definitely a discussion to have with your treating physician. And I think they can help guide you in terms of whether or not they think a hematologist would be an added value to the care you're getting.
Got it. Thanks. We got a few minutes left. Let's shift a little bit to research. Pat says, my husband has PNETs with a heavy liver tumor burden. What are your thoughts on the clinical trial drug cabozantinib?
Yeah, so we're all very excited about cabozantinib. Cabozantinib is a therapy currently under investigation for neuroendocrine tumors, and it's a therapy that's under a class of kind of what we call TKIs or tyrosine kinase inhibitors, and they have multiple mechanisms of action that we think they can decrease the proliferation or growth of cancer cells. And so there is earlier phase data supporting the use of cabozantinib for neuroendocrine tumors. There's good safety data that's safe for our patients. And then also some early what we call efficacy data that that we're seeing kind of its ability to control the cancer. there is a huge study going on right now through the cooperative groups, which is sort of the National Cancer Institute, looking at cabozantinib versus placebo, or so giving giving you not a therapy, basically. And so that's really, we're trying to sort out whether we see a difference there in terms of how the drug controls the cancer. And I think if that's a positive study, it's likely going to potentially be another tool that we're going to have approved to care for neuroendocrine tumors. So, I think there's a lot of excitement in relation to cabozantinib. We have the study open here at MSK, and we're enrolling patients. And I think it could be a good tool to treat the cancer. It depends a little bit on the therapies that, the patient has had, deciding whether or not now's the time to consider cabozantinib or the clinical trial versus some of the other treatments we have. So that, I would take that back to your doctor to talk to them a little bit more. But I think that there's very good data there. We're hoping for a positive result from the study. And we're hoping it'll be an approved tool.
Got it. Thank you. Are there any studies that you're involved with currently that you're excited about, or areas of that you're interested in possibly studying?
Yeah, I mean, I think there's a lot of excitement in the NET world in general in terms of research. Over the past decade, we've had so many therapies approved based on really, really large clinical trials that have been done. And so now we're working very, very hard to try to figure out how to sequence all of these therapies.
Right.
That's the huge question mark in this field. There's so many therapies. When do I decide to give this therapy versus that therapy? And so a lot of the studies that are ongoing now are trying to answer that sequencing question. So I'm very excited about those sequencing studies, as I think they're going to give me better data to take back to my patients in clinic and say, this is why I think we should do chemo now versus the PRRT, or this is why I think we should do everolimus now versus another therapy. And so, we have some of those sequencing studies open here, and I'm very excited about those studies. I think with the approval of PRRT, we're all very excited to better understand specifically where PRRT should fall into our algorithm. Right now it's approved after your cancer grows on the hormone injections, but there are studies ongoing right now looking at using PRRT earlier. And so I think I really do look forward to that data. And then I think on the other side of things, putting aside our treatments specifically, there's a lot to learn kind of more about the cancer genetics of neuroendocrine tumors. And there's a ton of work going into that. Again, I said it's a very, very collaborative field, and all of us who are focused in the care of our patients with NETs are trying to work together, especially for sort of the rarer subsets of this disease, to try to pool our data and answer really important questions related to genetics and therapy response together. And so, I would say those are the things I'm very, very excited about. The other thing that I think is really, really important and is a passion of mine, appreciating that everyone, people can live for so long with this disease, is really emphasizing the role of quality of life in the clinical trials we conduct, but also doing dedicated, studies, looking at quality of life in our patients with neuroendocrine tumors. And, we had a quality of life study opened for a few years that accrued very, very, very quickly. And I think, exhibits the passion that our patients have for that topic. And I think that's another aspect of neuroendocrine research that I'm very excited and passionate about.
Totally agree. Probably last question from Steve. Do you agree with removing the primary tumor after the cancer has spread? And are there studies to show the benefits of that?
That's a great question. So in general, if the cancer has spread, there's really not a role for removing that primary tumor. There's good data from solid tumors or solid cancers in general, that probably, while we thought that might be helpful, it generally is not helpful. I mean, rare exceptions to when we consider removing that primary is if it's specifically causing problems. So some patients with small bowel neuroendocrine tumors, that primary can cause a bowel obstruction. And if you're having a lot of symptoms and we're worried you're at risk of a bowel obstruction, or you've had a bowel obstruction, then yes, we may think about removing it more as for palliation of symptoms, but removing it in and of itself doesn't help us treat your cancer better. So generally, no. we don't remove that primary tumor in the setting of the cancer going to other parts of the body.
Got it. Thank you so much, folks. That is going to be our show today. The special announcement is that, well, I know we were off last week, but we were also going to be off next week for a very special reason. It is my 40th birthday, and I will be out of the country with my wife without the kids. So I'm very excited about that. So CCF was gracious enough to allow me to celebrate that in a wonderful way. So we'll be off one next week, and then we will be back the week right after that, which is the 23rd of June. And then from there out, okay, no more breaks until the fall, until holiday time. Okay, folks. But I need every single one of you to wish me happy birthday right now on this show. And if you want to give me a present, a donation to the foundation is always welcome. They did not put me up to that. That comes straight from me because I am so grateful for all the opportunity they've given me. Dr. Raj, amazing show today. Amazing, thorough answers. We've had well over 100 people the whole time. Thank you so much for being here and sharing your experience and your passion and your knowledge with us.
Thank you very much for having me. And happy birthday.
Thank you so much. One week exactly from today, folks, I will be on a beach in Belize. I promise you that. And listen, thanks to you all at home, as always. This show is for you. You are the fuel behind it. This is why we do this show. But we hope that this program helped answer some of your questions. I'll reiterate one more time. If you have follow-up questions, reach out to CCF either at carcinoid.org, their website, which is featured right behind me, or here on the Facebook page. You can send them a private message. Thanks again to our presenting sponsor, Ipsen Biopharmaceuticals. We could not do the show without them. And finally, my name is Rain Bennett. I have been your host. Thank you so much for watching, and please join us next time in 2 weeks on Luncheon with the Experts. Stay healthy, stay safe, everyone. Bye-bye.